Welcome to our lecture with GOWME. Our mission, if you haven't been to our lectures before, is to create an educational platform for students, residents, healthcare professionals, pretty much anyone who's interested in wilderness and emergency medicine to learn more about the topics for free online and have access to different resources. So we try to have a lot of different speakers throughout the year to kind of showcase different opportunities. It can be nice for healthcare students and professionals, but also just for anyone who has an interest in it. A lot of it's interesting and good knowledge. If you're new here, you can join our mailing list with this QR code. I'll also send a link in the chat. So if you miss it now, you can join later. We do have lectures every other week during the school year. We send out other opportunities. At the end of every year, we have a fellowship showcase, and we do other things throughout the year. So it's definitely nice to join our mailing list. We don't do lectures in the summer, but we usually try to keep the mailing list going and have some opportunities over the summer to check out. Additionally, we have an Instagram and a YouTube. This lecture will be uploaded to YouTube along with all of our past lectures. So if there's anything you're interested in, feel free to check that out. We are doing a giveaway with Pit Viper. I will put a link in the chat. So if you've attended, your name gets entered into the drawing for that. So definitely make sure to do that to get your attendance for this lecture. This is our board here. Just some of the faces you might see while you attend our lectures. This is our schedule this semester. You can see some of the past lectures we've done and some upcoming lectures we have as well that sound really interesting. So definitely keep an eye out for those or check out our YouTube if you missed some of the past ones. And now I will go back and introduce Dr. McGowan. Dr. McGowan is an assistant professor of emergency medicine at the University of Louisville School of Medicine. She acts as an associate program director for the emergency medicine residency and is the clerkship director and rotation coordinator for several rotations for medical students and residents. Her professional interests include medical education and wilderness medicine. A fellow of the Academy of Wilderness Medicine, she is the faculty advisor for the School of Medicine's Wilderness Medicine Interest Group. She has also been an invited faculty instructor for several wilderness medicine courses in the region and in France, and is an elected section counselor for the American Academy of Emergency Medicine, the Young Physicians section, and Women in Emergency Medicine sections. Outside of medicine, she is a world and national champion equestrian, loves hiking and diving, and is a proud crazy cat mom. An avid explorer, she has visited over 45 countries on all 7 continents, included working as an expedition physician to Antarctica. So thank you, Dr. McGowan, for coming. I will stop sharing my screen and turn it over to you.
All right. And thank you, Christina, for having me. And thank you guys all for tuning in. I know everyone's busy during medical school right now and has plenty of things they could be doing on a beautiful Tuesday evening. So I do appreciate you taking your time. I'm going to get my screen sharing going here. We'll see if I can try to not be a boomer and get this done. You guys able to see that?
Yes.
All right, cool. All right, so we're going to talk about in-flight emergencies tonight, which is not your typical wilderness medicine environment, but it's the same principles of wilderness medicine that apply. This is going to be kind of an informal talk. At any point, if you guys have a question or something, feel free to jump in, interrupt me. I like to keep this kind of laid back and casual and let you guys know at any point. I'm happy to take questions, concerns. So we're going to talk about in-flight emergencies again, or the dreaded call of is there a doctor on board, which most of you, if you fly frequently, are going to have happen. We have some statistics on how often it happens in the next few slides, but this is a pretty frequent one, whereas we talk about, being out hiking in the backcountry, most things it's going to be a sprained ankle or something like that is going to be what you encounter. Whereas on a flight emergency, you're not going to be with your typical outdoorsy wilderness healthy people. You're going to be with grannies that have multiple medical comorbidities, all of those things. So it's kind of more your typical hospital patient population, but in a more austere environment. Because remember, we describe wilderness medicine as any kind of medical situation in which your definitive medical care is greater than an hour away. So very easy to imagine if you're halfway across the Atlantic on a transcontinental flight that it's You're going to have limited resources, limited people to help you in some pretty serious situations sometimes. So what is the incidence of this? So there's really no exact definition or database used to track these. It's kind of the flights or the airlines kind of report to a database, but it's all elective what they report. There's no mandatory thing. And obviously there's different countries participating. So it's really hard to imagine exactly how many there are each year. The best they can gather is that there's one emergency per about every 600 flights, or about 24 to 130 emergencies per 1 million passengers. Now, what do you define as a medical emergency? Are these the ones only where a physician is called? That's typically what's factored into these statistics here. About 70% of these are managed exclusively by the cabin crews without ever calling overhead, oh my gosh, is there a doctor on board? And of those that do require is there a doctor on board kind of call, or a more significant emergency, usually about 7% of those are requiring diversion. So a fairly small number. These statistics come from an article in the New England Journal of Medicine from about 10 years ago. So a little out of date, but this is the only large study that has really looked at all of the smaller studies and tried to do a larger meta-analysis of the data that was out there. So we just don't have great data, but it's not uncommon for in our lives, if you fly 600 times, 600 flights, that's not uncommon that each of you are going to be the one that are tasked with responding to these. So what are your most common emergencies? Again, these are the ones in which flight attendants felt that they couldn't manage on their own. So a little stubbed toe where I need a Band-Aid, you're not going to get called on. Syncope and near syncope is very common, which makes sense. If you think of an elderly population or anyone that might have some health comorbidities that's maybe been sitting for a long period of time on a flight and then stands up to get their bag or stands up suddenly, maybe they get orthostatic. Maybe they've not drank enough fluids because they've been traveling all day. Maybe they skipped a meal. Not uncommon for the blood pressure to drop and for these people to syncopize. Usually with those, we know a little bit of benign, sit down, fuss over them, get them something to drink. A lot of those people are going to do pretty well. And more concerning might be some of the other ones. Respiratory impairment, you're a little limited, and we'll talk about supplies on the next few slides, but you're limited what you can do with somebody that has a true respiratory emergency on a flight. Nausea and vomiting, luckily fairly self-limiting for a lot of people. Maybe they had gastroenteritis, maybe they got seasick during some rough air, or seasick. Sorry, I do on the ship emergency lecture as well. Maybe they got sick from the turbulence while they were in the air, and then now they've had some vomiting. Again, something you can probably get people through. However, cardiac conditions, so somebody who might be in atrial fibrillation with RVR, or someone that's having chest pain, well, you're a bit limited how you can assess these people on the plane and what you can do even if you are able to do a good assessment. And then neurologic conditions. I don't know about you guys, but I don't carry TPA in my bag. So somebody that you think is having an acute stroke would be a very common reason you might need to divert that flight if you're able to. So seizures, things like that, although we see them commonly in a healthcare setting, seizures are a lot scarier out in like a wilderness environment because you don't have the resources. And most of us, unfortunately, have the knowledge that if we can't get this person to stop seizing, and by that, I mean, if it doesn't stop on their own, we're going to be pretty limited what we can do. So neurologic conditions, although only 5%, can be a kind of a scary proportion of that. So you're going to hope you get like the syncope or the nausea and vomiting in these cases. So what's the legal stuff? A lot of people always ask, well, do I want to respond? Do I have to respond? Ethically, should I respond? Am I going to get sued? Because if you guys are practicing in the States, you will find that everybody loves to sue for everything. And because of that, luckily, back in the 1988, probably before most of you were born, I'm feeling old, that was when the United States came up with this Aviation Medical Assistance Act. And basically, unless you are grossly negligent or willfully have willful misconduct, you are completely free of liability. So unless you say, well, I'm a first-year med student and, I saw a crike once on TV, I can totally crike this person that says I need my inhaler. Does anyone have an inhaler I can use? As long as you don't try to crike that person, if you're acting in good faith within your scope of training, what you feel comfortable with, you're basically not going to ever get sued. Unfortunately, there's no international equivalent to this. So if you're flying a US airline to Europe, you're great. If you're flying a European airline and are taking the flight from the States to Europe, then maybe think about, okay, well, again, I wouldn't say don't respond to an emergency, but keep in mind that there may have to have different protections depending on the country in which the airline is operating out of. However, you're not required to respond in the United States or Canada. If you're a physician or have a medical background and have sufficient credentials, you are legally required to respond in Australia and several European countries. So most of us do it out of the goodness of our heart, but understand if you're flying in Australia, you are legally required to respond. Now, I don't know how they're going to prove that this random passenger was a physician and that you knew about this law if you didn't respond. But ethically, I think most of us choose if you're in a state of mind in which you are able to respond, if you haven't taken like sleeping pills for a long flight or alcohol or whatever you might have done, you are legally obligated to respond in those. So keep that in mind if you're ever like trying to hide under your blanket and pretend you didn't hear the call. The good news is, in the States, there has never ever been a case in the States heard in court against a physician volunteer providing medical care. There was one time that a suit was filed, but it was dismissed without even a hearing. The judge immediately saw that and basically said, no, this is a bunch of crap, and it got kicked out, it was dismissed. So that's good to know. So even if you're still worried about liability, especially if you're in the States or on a US-based airline, essentially know there is near zero risk of you ever getting sued. And remember, you guys have all probably seen some crazy articles in the news about people. I think there was a urologist that like used a straw to do like and a needle to do like a suprapubic tap and like aspirated with like oral suction because they had nothing else. Like there's some crazy stories out there. If people aren't getting sued for that, you going to help Granny that's syncopized, you're going to be just fine. The caveat of that is, remember, you are a volunteer, so it is poor form / illegal to say, I would like to be compensated for this. If you were to demand compensation, that would also put you in a completely different category of legal responsibility, in which if you're getting compensation, they absolutely can sue you. However, you can accept any kind of tokens of gratitude that are offered to you as long as you didn't coerce or ask for those tokens of gratitude. That will not compromise your volunteer status or your Good Samaritan status with the airline. It's very common to be offered these things. Usually it's in the form of, here's some bonus miles on your account. Do you have a frequent flyer account? Or here's a flight voucher. Hey, we've got a seat in first class. Do you want to get upgraded to first class for the rest of the flight? Like, here's a bottle of champagne as you're departing. Here's a whole basket of snacks. Here's the first class snacks. Totally fair game to accept those things. It doesn't make a difference on your legal liability if you decide to accept those things or not. And you will find that when you do respond to these emergencies, the flight attendants are almost universally incredibly grateful for your assistance and are very eager to do whatever they can to try to make your flight as comfortable as possible. And although I have no proof of it, I swear there's some kind of database that you go into when you've assisted with these in the past, because I had an instance where I'd responded twice in the same flight. And the next like 6 flights with that same airline, I just kept randomly getting upgraded to like an exit row seat, or I'd have an aisle all to myself, or little things like that I'm like, this is more than just karma. I think there's some kind of thing that, and then there are some airlines that actually you can, I think Spirit randomly is one that you can put when you're putting in your flight details for your frequent flyer accounts and actually say, I'm a medical professional and I am willing to help in assist in a medical emergency, in which case then they actually will sometimes come to you in your seat. That was how I ended up on 2 on the same flight. I told them on the first one, I'm a doctor, I don't mind to help out. They actually came specifically to me and said, hey, we have another person, would you be willing to come and assist? So there are ways to kind of put yourself in a database for that. One of my partners says he actually puts doctor first name whenever he's registering himself, or as his preferred prefix, specifically so they know he's a physician in case they ever need someone to assist. So do with that information what you may, but don't fear taking compensation or in the form of vouchers and those kind of things, but do not ask for like cash compensation or anything like that. So do you have to prove that you're a doctor? Flight crews are told that they should ask for some form of credentials to show that they are actually getting someone who is a legitimate physician or equivalent to provide their care. That being said, in my experience, most of the time, if you walk up calmly, confidently say, hey, in my example, I'm like, hey, I'm an emergency medicine physician. I'm happy to take a look if you guys need help. But if you're good, I'm perfectly happy to go back to my seat. And usually then they kind of know that's, I'm not running in as a crazy bystander saying, oh my gosh, yeah, I'm totally fine for this. Let me at them. Usually they're like, fine. I think I've been asked one time if to provide credentials, but usually every other time they're just happy to have you and can kind of tell just from your body language and how you interact with people that you know what you're doing. It is best practice to have some form of proof on your phone, and you'll find that most of you guys, once you start your residencies or credentialing for hospital systems, are going to be asked so many times to provide a picture of your medical school diploma or your state licensing board, or in my example, for my board certification. You have to provide these things so often to different credentialing agencies and state licensing boards. You just have a file of them on your cell phone anyway, so it's pretty easy to pull them up, scroll through, and be like, which one do you want? And they're like, okay, cool. But even at your stage, as medical students, having a picture of your medical school student ID would be completely appropriate for something like this. And just be clear when you walk up, hey, I'm a medical student. I'm not a physician, but I'm happy to help, if you need it. And oftentimes you will find that as a senior medical student that's fresh off your rotations, you might be way more comfortable and qualified to respond than maybe a ophthalmologist that has been out for, out of residency for 40 years that has not seen anything but an eyeball in that time. So don't be afraid to step up. And oftentimes most cases it will be like a nurse or like a EMT that replies, and you guys might very much add value and they will welcome the help, both the flight crew and the other medical professionals there. So don't be afraid, even at your level of training, to jump in and get involved. So what do you have to work with? So this is what you have in the US. Luckily, with this, the Federal Aviation Administration also came up with this emergency medical kit. And at first glance, you're like, oh, sweet, I got medications, I can work with this. You look at it more and you're like, all right, well, I've got a bunch of needles and some like syringes. Okay, I've got some gloves and a mask. There's a blood pressure cuff, tourniquet. I can do some stuff with this. Oh, band-aids. Great. We got some band-aids on here and some scissors. Okay. You look at the meds and you're like, all right, aspirin, that's useful if someone's having chest pain. I've got an albuterol inhaler essentially there. I've got epi. Oh man, I got to remember the concentrations and I've got to draw it up out of a vial myself. All right, a little more problematic, but we got this. I've got some Tylenol. Oh man, I don't even have ibuprofen in here. Oh, okay. And then of note, all airplanes that fly commercial flights with a flight attendant with 30 or more passengers have to have an AED. So you should always have an AED. Now, what was not in that list? You don't have a pulse oximeter. You don't have a glucometer. There's no thermometer. So during the COVID era, that became a little more important. You have no Narcan, which unfortunately in this day and age, that's something that can very much save a life, even on a flight. You have no suction capabilities. You don't have an EpiPen. You just have epinephrine in a vial that you need to know the dosing and be comfortable drawing up out of the correct epinephrine concentration, the correct dose, and administering yourself, as opposed to just stabbing someone with an EpiPen that's pretty foolproof. So there's definitely things missing from there, and you should keep that in mind. Now, there are some expanded kits. This is not mandatory, but a lot of countries or airlines will have this expanded kit. The good news with this is it's almost full airway equipment. You've got McGill's if somebody aspirates something and you're trying to pull a hunk of aspirated sandwich out of their airway. You've got a nasal cannula. You've got an oxygen delivery system. You've got bag valve masks in various sizes. You can tube these people. Oh, great. Now you've got your suction pump and catheters, sterile drapes. I don't know who's doing things sterile on the plane, but have at it. You'll have some then. You've got way more medications. And some of these, I'm like, oh, wow, well, these things make sense. Like somebody has diarrhea. Now we have Imodium. Like these things make sense. We have Zofran now. Great. Common things being common, the nausea, vomiting being 10%, having some meclizine and Zofran on board, you are in business. Slap a scopolamine patch on if you want, and you could really get somebody through. And this one as well has Narcan. So this is great if they have an expanded kit, but remember, a lot of places aren't going to. So if you have a seizure patient here, great, you've got some Valium to give them. I don't know who's giving Lasix on these flights, but have at it. But a lot of these things would be very useful if you had this expanded kit. International kits, total crapshoot. You have no idea what's in that bag. It's a total surprise. One of my partners at the hospital tells a story about how they were flying some South American airline. They were in the skies over Argentina. They get called for a doctor on board. It's a patient in first class who is completely unconscious, unresponsive, GCS3 with a blown pupil, and a husband that said, yeah, she was complaining of a headache all day and then she just went unresponsive. This patient was obviously having a massive intracranial hemorrhage, and needed to land, but they pulled out their doctor bag and they found they had full airway equipment, full IV supplies, and essentially an entire code cart and a number of different medications. And they were able to get the patient intubated, get the flight diverted, and land, and had a pretty good outcome. Other times I've been on an international flight before where I was like, oh, cool, like, what do you have in there? And they pull it out. I was like, oh, we have some Band-Aids, a stethoscope that is pretty useless with all the engine of the plane noise, and like aspirin. I was like, oh, cool. Less exciting than I was expecting. So you just never know what you're going to get. So use your creative skills.
Dr. McGowan, we had a quick question in the
Yeah,
chat. Someone asked if there's a reason why EpiPens aren't included, because they'd probably be much easier to use, you would think, if there's something
all
behind
about
that reasoning.
Yeah, it's all about the dollar bills. EpiPens are expensive. You guys see in the news, it's like $300 for a 2-pack. It's much easier. You can get a pack of the little 2 milligram vials, and it costs pennies on the dollar. So that's actually one thing I teach my residents. And I was like, if you're ever putting together a kit, it is way easier to get a vial of epinephrine. It's like $1 or something crazy like that, and just build your own anaphylaxis kit than it is to try to afford an actual EpiPen. I mean, it cost me, I put them together for my wilderness medicine interest group leaders, and all the supplies, including a little kit off of Amazon, cost me less than $8 a kit. So, and it basically comes down to cost. EpiPens are oftentimes just going to get expired and not used on the plane and tossed. The number of times they're going to use them does not warrant the cost of carrying one on every flight across the country. So it's the unfortunate reality. But yeah, there's actually a lawsuit filed against one of the airlines in which I think they had an EpiPen, but it was only the adult EpiPen, and it was a child. And I think basically they freaked out because it was adult and they didn't give it to the kid. And I can't remember if the kid had a bad outcome or not, but I don't think it was good. Which in that situation, for everyone's knowledge, you should just give the adult dose. But I guess they didn't, because someone was afraid about what happens if you give an adult EpiPen, or maybe it was delayed. And anyway, so now there was a lawsuit and somebody was actively trying to get it changed so that all airlines were required to carry like pediatric medications, including like pediatric EpiPens. But in reality, it's not going to happen because it's just the number of pediatric complaints in these cases is so minor, or compared to the adult ones, it's just not cost effective. And unfortunately, we all know cost drives all in healthcare and in aerospace travel. So but yeah, so what are your options if you're in the midst of dealing with a medical emergency? You will always have a ground-based telemedicine support, and they can help you with both the medical care. So if you're like, hey man, I'm a med student, I'm comfortable with some of this stuff, but like, I just want somebody to double check me. Am I supposed to be doing this like 1 to 1,000, 1 to 10,000? What's my dose on the epi? This person's in anaphylaxis. I can give them a shot, but like, your Wi-Fi wasn't free. I can't just Google this. You want to help me out with this? They're going to be happy to help you with that kind of stuff. They also are there for all the stuff that you wouldn't dream of, all the logistical things. The ground crew is going to be who coordinates getting an ambulance to meet you at the jet bridge. They're going to tell you, oh, no, don't land in that city. Go 5 minutes sooner, divert to this country, whatever it is, because they know where you need to land, that you're going to get the best medical care. They're going to know specific hospitals for the crew, for you to be able to tell the medic crew that shows up, this person should go to this place, because this is their job. They stay on top of this and they know the specific needs for that patient based on what you're telling them. And then the other thing, remember, the ground crew is actually who's in charge, which we'll get to on the next slides. But be very agreeable if the cabin crew wants you to speak with them. Usually there's going to be some form of communication on anything more serious at all. And don't be that person that like refuses to speak to ground crew, or just be like, well, just like relay a message for me. If they say we need you to talk to the ground crew, you need to do that, because the alternative is you could get completely pulled off the case and told, go back to your seat. You are no longer allowed to volunteer. So play nicely with others. Don't usually have to tell you. Those in the wilderness medicine, emergency medicine interested population tend to be team players, but we all know there are certainly some out there that are not as good of team players in medicine. So diversion, we've talked it through. You've now responded to the call. You've assessed your patient. You've looked through your stuff and you're like, diversion, what about it? So cardiac arrest is going to be 57% the most common reason to divert a flight. Luckily, this one's kind of common sense. If somebody is in active cardiac arrest and you're doing CPR on them, you're probably going to want to divert that flight. Unfortunately, there are going to be some instances in which you can't just divert if you're in the middle halfway between two different continents. It's not that easy. And realistically, you're not going to keep CPR up for 4 hours on someone. There will be times when, in conjunction with ground crews, you might be calling this in the air, unfortunately, and saying this is futile care. And remember, even if you get someone back, the odds of keeping them alive until they rearrest are going to be pretty slim. So unfortunately, not a very good outcome if someone has a cardiac arrest. Luckily, it's only 0.2% of medical emergencies. Unluckily, if you do the math on that, that's about 1 death per day of flights worldwide. So somewhere in the world every day, someone's dying on an airplane. And then I always thought this one's a little ironic. They consider cardiac arrest to be 86% of deaths, which I'm like, weird. I'm pretty sure 100% of people die of cardiac arrest. But I think they mean of those, all of them, including the people who get off the plane and, have a stroke and died at another hospital, things like that. The ones that are in-flight cardiac arrest account for 86% of the deaths, not including the ones that died at hospitals later, or including the ones that died at hospitals later. So other common reasons for diversion. So cardiac symptoms, again, we talked about there's not a whole lot you can do for someone that's having a STEMI, that's an AFib RVR, that's having these symptoms while you're in the flight. You're not going to have a 12-lead monitor. You're going to have an AED, but it's not going to be a monitor defibrillator. You're not going to have any way to get an EKG on these people. Although Apple Watches are actually a great thing that you could ask another passenger to borrow to try to get a 1-lead rhythm strip to at least see an underlying rhythm. But even then, even if you figure it out, there's not a lot you can do for a lot of these people. You can't cardiovert someone that's in VTAC if they're awake and talking to you. Obstetric emergencies. I don't know about you guys, but OB things make me nervous. Tiny humans born prematurely make me very nervous. So although they're only 0.7% of in-flight emergencies, that's 18% of total reasons to divert. Because if there's a pregnant person that says, I think I'm in labor and I'm only 32 weeks, my reply is going to be divert, 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 get this person down. I do not want to deliver a baby and have to manage a preemie on an airplane. So very common reason to revert there. And then suspected strokes, as you can imagine, as stroke always says, time is brain. So anytime that patient is on the flight, not at definitive medical care, that window to give TPA or any kind of interventions is closing. So a very common reason to divert is going to be somebody that you think might be having a stroke to try to get them to definitive care within that window. And then diversion. So what does it actually cost to divert a flight, and why do they not take this lightly? It's up to $1 million to divert a flight. And this isn't just international. This is just a run-of-the-mill. I live in Louisville, Kentucky. Delta flies Atlanta to Louisville dozens of times a day. It's a huge cost even for just a regional flight like that. The good news is it's not your decision. The bad news is it's also not your decision. It is up to the ground crew. You're going to talk to the cabin. You're going to talk to the ground crew, and they're usually going to follow your advice, but there's going to be times where the captain's going to say, hey man, there's storms down here. The fuel reserves, we can't dump fuel in this area. There's not a landing strip. The only place we could divert to is in podunk middle of nowhere, and they're not going to even have a hospital. They'd have to transfer them out. So there's going to be some times where you're told when you're saying, I need to divert this person, they're going to be like, hey, that's just not possible. Other times saying, it's only 20 minutes farther. It's just not, we're just not able to do that. So you do have to listen to them. Ground medical control is also going to be very involved in these decisions. I would always leave them in their hands. They will ask your opinion, and you're welcome to give your opinion, but know that it's ultimately going to be their decision. They know legally, though, it's going to be very hard for them to ignore your advice. So if you say, I would recommend diversion and it's feasible, they're going to make it happen. Interestingly, I really like this one. One study found that the presence of a physician on board responding to an in-flight emergency significantly increased the likelihood of a diversion, and it increased the likelihood that the patient, when they went to the hospital, was going to get admitted. And that's fair. If I'm a physician in a hospital and I am brought a patient by EMS and they say, well, gosh, this was a transcontinental flight, and there was a doc on board that said, oh my gosh, I think this person's having a heart attack, and they diverted the whole flight and landed here, and we rushed them right here to you. It's going to be kind of hard for me to not go with the flow and say, oh yeah, your stuff looks fine. We'll just send you on home. Good luck getting across the country now. It's most places they're going to say, oh yeah, okay, we'll go ahead and admit this person and do a workup on them. So your opinion as a physician carries a lot of weight. So keep that in mind. Do what's best for the patient, but don't feel that you have to say every single person has to be diverted. This person got bumped on the head. They're probably going to be okay to continue on if they didn't lose consciousness, if they're not on blood thinners and they're a GCS 15 without focal deficits. So keep in mind your decision is heavily weighed and everybody wants to do what's best for the patient. So keep that in mind as you're making recommendations. So basics to consider that you don't really think about until you're in the situation in which you need to. It's best to keep the patient in their seat or just trade them like within the same row if possible, because there's not a lot of room on the airplane. If the patient has syncopized or similar and is laying out in the aisle, it's much better to move them out of the aisle. You really don't want to pull someone out of their seat and try to take care of them in the aisle. Because you just think about it, all the other passengers are going to be looking in this day and age, videoing. The patient's going to feel awkward. There's not much privacy, and you're very cramped in there. If you do have to move the patient, trying to take them to first class, those lay flight seats are amazing to take care of a patient in. The galley area near the kitchen usually has a lot of room. And then think about those front row seats with all the leg room. You can totally commandeer the leg room there. There's usually more space around the restrooms if you need to lay that person flat. But if at all possible, you want to try to keep them in their seat if you can, with obviously caveats. There's going to be times you can't. But if you have to do CPR on someone, please don't do it out in the middle of the alleyway. In the aisle, just take them to the back in the galley, something like that, to get them out of the public's eye and get yourself off of Facebook Live. Other things you might not have thought about that we wouldn't do in a hospital, you can totally ask to borrow supplies from other passengers. So if you have someone that has anginal sounding chest pain, you open up the kit, there's no nitroglycerin in there. There's probably someone on the plane that has a bottle of nitro that their cardiologist told them to carry at all times. Likewise, statistically, someone on that plane is going to be a diabetic and probably would have a glucometer there. It's okay to say, does anyone have ibuprofen? Does anyone on board happen to have this medication? And that's part of your job as a physician. If you can look at this and it's in a vial that, the medication looks like it's been stored properly, it's clearly labeled with the medication, the dose, expiration date, you look in, you're like, okay, there's not like 8 different pills mixed in here. This person seems reliable. If you need the medication, it's not unreasonable to ask and borrow and do that. Just make sure the patient is aware of the risk if they're able to consent and say, yes, I'm aware I'm taking this out of this guy named Jim's bag over here that I'm not totally sure, but this seems kind of reasonable, especially if you have like in-flight Wi-Fi. If you're able to confirm, like look up, there's like pill ID and just make sure you're giving what you think you're giving, that would be best. And again, this is going to be for medications like nitroglycerin or something that could really make a difference, not for, Granny that says, well, I think I might have forgot to take my blood pressure medicine this morning, but is otherwise asymptomatic. You're like, Granny, you'll be fine. Continue on. So another thing to think about is this is essentially a form of altitude medicine. I saw on your all sheet that it looks like you guys might have had a lecture recently on altitude medicine. So awesome. Same thing. So Dalton's law, as your oxygen or as your atmospheric pressure drops as you ascend in altitude, you're going to have a lower partial pressure of oxygen. So the planes are all pressurized to about the elevation of Aspen, Colorado. So kind of a low, high altitude environment. So those who live at sea level that already have cardiopulmonary compromise, maybe they're a COPD that lives with an oxygen saturation of around 90, baseline when they're on the plane, their SAT is now going to be about 3 to 5% lower. So it's probably worse than it was when they got on the plane. So the COPD that hangs out 88 to 90, maybe they got kicked off a mild exacerbation from exerting through the plane, trying to make their flight. Now you go take them up to altitude, they don't have their medications, their SATs might be 80% and they might be pretty symptomatic. You do have supplemental oxygen on the plane, but it's usually a pretty small tank. So be considerate of that. Most of us are used to a hospital environment where you can crank up a patient on a non-rebreather and call it a day because the hospital's oxygen supply is not going to run out. For those that have worked in EMS, your tank is a finite amount of oxygen. So, and again, you probably don't even have a pulse ox. So these are people I would start on a liter or two and see how they do, and try to go from there. Don't put them right on a non-rebreather and use up your whole tank in just a couple of minutes. The plane does have, the capabilities for all the oxygen masks to drop down. Everybody has oxygen, but that's not something you can access with your patient. You can't just be like, hey, can I tap into the plane's oxygen supply and those masks? That's not a thing. So don't think that it's an unlimited supply. I always tell my residents, if you ever have a patient encounter, it needs to be documented. So whether you saw someone informally and gave advice, if you had a full encounter in the ED, if you're a consultant that comes down to see a patient, you always have to document. And that's no different here because that's best practice as you're practicing medicine. So some flights have incident report forms. Some of these are now digitalized where they just like hand you a little iPad and you go through and write it all down, click the boxes and call it a day, and it gets transmitted back to ground control or to their however they store their records. Other places, there might not be any official way to keep the records. You can ask for a blank piece of paper. They might or might not want it. If you're going to be handing off to an EMS crew, if you're diverting the flight, definitely would recommend kind of having a coherent narrative of what happened, so it's not third, fourth hand of people trying to relay things when they all actually get to the hospital. If you have nothing else, you can keep just notes on your cell phone. I would always advise whatever you do for documentation, keep a copy for yourself, because you just never know if you're ever going to get contacted again about this incident for further clarification, or what did you do, when did you do it? And if you're going to be the first lawsuit to ever get brought forth to a court over malpractice, you'd probably want to have a copy of your own documentation. So keep some documentation of what you did, what you saw, all of those things. But it doesn't have to be super elaborate. It's not like you need a full H&P for these people. I usually just jot down a couple sentences in my cell phone. Patient felt dizzy, wanted their blood pressure checked blood pressure. It was X. Told them to, drink some water and see if they feel better. Patient said they felt fine. Because in reality, that's what a lot of these encounters are going to be, very basic things that you're like, oh man, I could have, as a pre-med student, handled that. Don't forget your PPE. Luckily, unluckily in this day and age, gloves and face masks are plentiful. You can ask the flight attendants, they're gonna have a whole bag full of gloves and masks that you can borrow. You never know where these people have been, what they've been up to, what diseases they might have. It is not worth the risk to you to be doing things without proper PPE. So if you are gonna be trying to put an IV in somebody or having hands-on patients care, definitely ask for gloves. If a person has respiratory symptoms, put a mask on. It just takes a minute, and you really just, I don't know, I always say, I don't like to touch people barehanded. It's not my thing. So I'm a big proponent for PPE, and, they have plenty on the plane, even if it's not in the kit directly, although it should be. And then other things to keep in mind, what you're doing, you're going to be doing the best job you can. There is no standard of care for in-flight emergencies because there's no record keeping of these. There's a limited equipment. Your kit may or may not be missing things. It may or may not be expired. You're going to do the best you can. This is truly wilderness medicine. There's near zero liability, and they're going to be so grateful that you tried to offer your skills. So don't fear helping. And then I originally gave this lecture to my residents, so I had to throw in the plug. I'm not shaming anyone that might has a different pathway in their life, but when they call for a doctor on board, they're not asking for an ophthalmologist. They're not asking for a psychiatrist in most cases. As an emergency medicine physician, or those of you with wilderness medicine training, and arguably those who come from a family medicine background, you're going to be the most qualified person to respond to that emergency. You are who they are asking for. So although you might be a senior medical student or an intern, if you go up there and there's, an orthopedic surgeon and a psychiatrist there, you're probably still going to be the most qualified person. So don't get imposter syndrome and don't be afraid to go up there and get involved. All you have to do is say, I'm EM, or I have wilderness medicine training, or I have a family medicine background. They know what those things mean. And they love, especially emergency physicians, because they're like, okay, cool, got it. Ground control is emergency medicine physicians, typically. University of Arizona, I believe, is one of the places that does it. Maybe Pittsburgh as well. They might be Flight. But anyway, they know what emergency medicine physician means. Oftentimes, in the hospital setting, emergency medicine physicians, we always say poop rolls downhill, and we're one of the most hated specialists in the ED when we call consults, because all we do is create more work for everybody else in the hospital system. However, on a plane, when you show up and the ophthalmologist is trying to remember what those ABCs stood for that they learned about so long ago, kidding, opto's great. They're going to be very happy when you show up and they're like, oh, good, you got this. I am out. Have a nice day. I'm going back to my glass of wine. So don't be afraid to help. You've got this. You're qualified. Definitely within your scope to do this. Even you guys as students. I know some of you are still students. So that is all I have for that. I am going to then see if I see some things popping up in the chat, but if there's any questions there. Is an ortho doc going to respond? I'm going to stop sharing here. Is an ortho doc going to respond? Well, I mean, if they came over the speaker and said, hey, this person on medical emergency, and they look over and it looks like their forearm is misshapen, well, then they might very well be willing to respond to that. But as a general, yes. Ortho is probably not going to get involved. That's all I have. I'm happy to open this up for questions if anybody has any here. I think, like she said, we're recording this, so things will be uploaded, but.
Yeah, if anyone has questions, feel free to unmute yourself and ask, or type in the chat, if that's easier. I was wondering if you have any particular interesting like story you've had, or like one of your colleagues that you've heard of on a flight?
Yeah, so like I said, one of my colleagues, the one that intubated the person, kind of takes the cake on that one. And that one ultimately they ultimately got word back that it was a non-survivable head bleed, which was unfortunate, but um at least he was there and able to provide that assistance and at least get her and her husband to the hospital. Mine have all been admittedly relatively minor. I passed out. I think my blood sugar is low. I'm worried my blood pressure is high. I'm worried my blood pressure is low. I forgot to eat today. Can someone check my blood sugar? Usually a lot of very common things like that. I twisted my ankle. I forgot my inhaler. Do you guys have Band-Aids on board? Every time I've been called, it's been something pretty minor with supportive measures that I was able to do. I've only had to talk to ground control once, and that was just more of a courtesy. This is our policy. It was a very minor thing. I've not had to divert. I have been fortunate. Um, I know a few colleagues that have had a little more serious things, even some of our residents that have responded. I know one of our residents was talking about how they had to divert a chest pain, and they were the ones talking about how they had this iPad thing they had to fill out now, which was just kind of interesting to hear. I also do expedition medicine on ships, and I will say I've had much more of a black cloud on ships traveling, but same principles, limited equipment, small environment. And of that one, my favorite story is I sedated and cardioverted someone AFib RVR in the middle of like 20-foot seas with no backup. And that was my like best in transit emergency I've had. And I love it. I see someone else is pursuing their FOM. Good for you. See in the comments.
Well, if no one else has any more questions, y'all are free to go at any time or stick around for another minute or so. We'll stick around until you guys are all gone. But thank you for joining us today, and feel free to check out our YouTube for the other lectures. Keep an eye out for upcoming ones and everything.
Yeah, and if anyone has any questions to think of later, my email is jennifer.mcgowan@louisville.edu. So pretty self-explanatory from there. And you guys are welcome to shoot me an email or anything if anyone has any questions, concerns, comments, more ortho jokes. All right. Well, thank you so much for putting
Yeah.
this together. I really do
No, I
appreciate it.
appreciate you doing it and working with us. So everyone else on the board, no one else could join tonight, but they're all really excited to see it and everything. And when
Awesome.
when I have more information about I'll stop recording this because I feel like it's not important, but I feel like they don't look at it and cut it. So